Good morning, a happy day and a happy weekend. Those who are going to give exams, you can spend half the weekend on studying and the other half on rumination about the questions and some more little time, me time also. Now, I had made a presentation on pathogenesis of gallstones. The link is there. I'll be posting it in the comments. You can click there to get the main presentation. I made a few MCQs on the pathogenesis of gallstones. All these MCQs are in the Telegram channel also. The only thing is, in the Telegram channel, I'm not able to give much more explanation than just able to give the right answer. Now I'll be clicking off the video because, okay, as I told you, never substitute these online sessions for your clinical encounter with patients. And the pictures are from my collection. And if they have been taken from one of my colleagues or from the net or from my students, then I'll definitely give them their due credit. Now, gallstones are the most common biliary pathology. However, they are asymptomatic. Now, I didn't want to keep on covering the answers and then opening them one by one. It's a waste of your time first. No need to keep anything so suspenseful. Give the right answer and give the explanation. Tell why the wrong answer is wrong, and that's it. So, they are asymptomatic in 10%? No. The 10% is they are radiopaque. Now, whenever there are numericals, you will realize the numericals are used almost with authenticity, but reflecting some other issue. In 5%, see, the 10% has been fixed there to confuse you. That is for radiopaque stones and gallstones. So 5%, what happens? It is not 5%. 5% of the symptomatic ones will become symptomatic in 5 years. Is it 80%? Yes, 80% will be asymptomatic. Now, even asymptomatic gallbladders, they are treated with special indications, like in children with hemolytic anemias, or you're going to do an abdominal surgery for something else, and there are stones, you can remove them, or there is sludge in the gallbladder. Now you see the word sludge, they are very fine particles. They have lot of scope to go all over here and lodge into the pancreatic duct also and lead to pancreatitis, which is much worse than only stones in the gallbladder. Or they will go down, get into the hepatic ducts and cause cholangitis, which is much worse. So cholangitis and a pancreatitis is much worse than an acute cholecystitis itself. That's it, of course. So you will be treating even sludge, even if they have no biliary colic, there are no attack of cholecystitis, no attack of cholangitis, no attack of pancreatitis, you will still go ahead and remove the asymptomatic gallbladder. This 40% has been just introduced as a distractor. Now, in India, gallstone disease is highest in the following states, except where exactly you can make out from the graph, it is self-explanatory, except Karnataka. Now, if people from this area are coming with asymptomatic gallstones, it's also one indication, relative indication to operate on them. So keep this in mind. That does not mean there is no single case in Tamil Nadu. There is no single case in Andhra Pradesh. They are there. But comparatively, the incidence here is very high. Now, percentage of gallstones that can be diagnosed on a plain X-ray abdomen is 10%. You can see the gallstones. How do you know they are gallstones and not renal stones? One, they'll be near the 9th costal cartilage. And number two, they will be faceted. If you zoom this, you can see these mild faceting visible on the X-ray. 30% again is a distractor, 40% is a distractor. 90% has been introduced because renal stones are opaque in 90%. Okay, you can zoom and imagine. Now, all are true of mucocele of the gallbladder. Please don't run into the slides before me. Come with me. Now, bile pigments are all absorbed, hence almost colorless or white. It is true. You see, this bile here, which is being aspirated from the gallbladder, so that the gallbladder becomes easy to handle during surgery, is white. It is not like your bile color. Stone is impacted at the neck. Is it true? Is the stone impacted at the neck? No. It has to be impacted at the cystic duct. Then only you will get a mucocele. If the gallbladder is packed with stones, still you will not get a mucocele. One of the stones can get, if they go and impinge on the cystic duct, then you can get a mucocele. Otherwise, just by being packed will not produce a mucocele. Stone is impacted in the Hartmann's pouch. Impacting in the Hartmann's pouch may initiate a cholecystitis, but it is not going to make a mucocele. See, this is impacted. You can see the stone through the serosa. But still, this is the cystic duct that is patent, and you can see liquid bile coming out. See the difference between this bile and this bile. So the correct answer is bile pigments are all absorbed, hence the color is almost white. The stone cannot be impacted in the neck to form a mucocele. Packed gallstones cannot become a mucocele. Neither is an impaction in the Hartmann can produce a mucocele. So there's a question about cholecystokinin. It has the following actions. Does it increase food transit time in the duodenum? No, it does not increase the transit time. Causes relaxation of the sphincter of Oddi naturally for the bile to come out. Increases hepatic secretion of bile. Yes, it increases the hepatic secretion of bile also, and it also causes contraction of the gallbladder and relaxation of the sphincter of Oddi. Increases hepatic secretion. And how does it get stimulated? By fat and amino acids in the food which are entering the duodenum. So gallbladder motility can be measured by all except I've been telling that gallbladder motility is also one of the reasons for a stone formation. So if you have done a medical treatment or a shortwave lithotripsy and you find recurrence again, if you remove the gallbladder, you're not going to find a gallstone recurrence. You might find stones in the ducts, but not in the gallbladder. But if you have done a medical treatment or you have done a shortwave lithotripsy for the stones and you find them recurring, your next step will be automatically to look into the motility. So this you can do it with your ultrasound. Yes, this is the fasting state as I've explained in the main presentation. Gallbladder will be distended in the fasting state, and then after a meal it immediately comes down. That means the motility is quite okay. You can do radioisotope scans. I am not explaining the details. Finally, can endoscopic ultrasound tell you about gallbladder motility? No. Let's have a brief basics about endoscopic ultrasound. There is a small endoscope, there is a small ultrasound probe which you can introduce through the endoscope itself. And these areas which are not easily available through your endoscope itself to see, that means things beyond the stomach wall, nor can it be seen in your imaging like your CT, MRI and your abdominal ultrasound. You can take your probe and go and see nicely. So you can see the ducts. You can go nicely all over and see the ducts. Not only that, you can see the posterior part of the stomach, or you find a posterior mass in the stomach. You want to see whether the layers are involved, which may not be that easy on your external imaging. You want to see the pancreas. You want to do some therapy where you need to be very clear which part you are handling, so that you are not near blood vessels. You are near the field of interest. For all that, you can do an endoscopy ultrasound, but that will not tell the function. Apart from showing Doppler effect of the vessels, it will not show function of these ducts. So endoscopic ultrasound, it has got uses. I've told you the uses, but definitely not to look for the function of the gallbladder, the motility of the gallbladder. But it can look into the common, it cannot go into the common hepatic duct, but it can park here. It can go like this and park here and look at this ampulla better. That is your endoscopic ultrasound. Cholecystokinin provocation test. Yes, you can give cholecystokinin and see whether the gallbladder is contracting very well. As I told you, cholecystokinin has got actions. It will relax the sphincter of OD. It will increase the contraction of the gallbladder. So if you find a distended gallbladder, you gave cholecystokinin provocation test and you found it promptly shrinking, then you know the gallbladder mobility is normal. Sorry, the gallbladder motility is normal. Now, all these are true about black stones. They increase with age, true. 20 to 30%, they make up 20 to 30% of pigmented stones. And they don't have, do they have cholesterol? No cholesterol, no. Cholesterol is a must. That is the nidus of stone formation. The degree of amount of cholesterol differs between pure cholesterol stones, mixed stones, and pigment stones. And for some reason, it is common in cirrhotics with gallbladder disease and also in hemolytic anemias. So thank you all so much. You can follow my Telegram page and also go to the main presentation, YouTube presentation on pathogenesis of gallstones and check it out. At this stage, I want to thank my Indian students, which are contributing to 50% of my viewership, and they have another 50%. The top percentage is coming from, the biggest proportion is coming from Indonesia and Southeast Asian countries and also the UAE. So thank you all very much, and I'll be very happy if you can come on my YouTube channel, join my Telegram channel and ask specific doubts. I should be able to help you all in some way or the other. Thank you so much. Keep subscribing, keep sharing, keep liking, come to my Telegram channel and also comment in my YouTube channel. Thank you.